And you just emailed me your slides. Do you want me to pull those up?
Oh, you got them?
Yeah, I think so.
Oh, awesome. That's great. Okay. Yeah, obviously the reason I did it is because there's a big traffic jam, or there is still a big traffic jam on 95. So I've gotten off and I'm in some random parking lot in Stratford giving this presentation.
This is clearly a first for the interventional group. lectures on the highway.
All right. So let me just share my presentation, and if it's not working this way, then Dr. Fau can share. Can you guys see my screen? Not yet?
Not yet.
Okay, how about now?
Yes, we can.
All right. Excellent. All right. So my talk is on anticoagulation in PCI. Since the first description of coronary angioplasty by Grunzig, the technique, equipment, the associated pharmacotherapy has undergone substantial evolution, leading to significant improvements in peri-procedural complications. In particular, procedural anticoagulant therapy has been a focus of numerous clinical trials, and several options are now available and supported by practice guidelines. And each agent has its advantages and disadvantages. And procedural pharmacotherapy still continues to be a focus of drug development. So in this talk, we'll just sort of review the salient aspects of anticoagulation in PCI and evidence for various anticoagulants used in PCI. So this picture has been seen in probably half of interventional lectures as the first PCI by Grunzig in Zurich in 1977. The anticoagulant cocktail that they used at that time was IV heparin during the procedure, briefly held and then continued after the procedure. They used dextran, as an infusion during the procedure as well, which has a sort of mild antiplatelet and antithrombotic effects, and then aspirin. This was sort of the anticoagulant regimen that they used at that time. And it sort of remained so through the era of Ppca, which is in the 80s. The need for more intensive anticoagulation came along in the 90s when stents came along, and they really revolutionized angioplasty in the sense that there was less abrupt vessel closure and restenosis, but because of the presence of the metal stent, they necessitated more intense anticoagulation. And this slide is from the experience with Palmar shot stents. The protocol at that time was aspirin and dipyridamole, IV dextran infusion during the procedure, and they gave IV heparin, which was just interrupted for sheath removal, followed by warfarin for 1 to 3 months. The warfarin and the heparin was associated with a lot of bleeding complications at that time, and it was sort of a two-edged sword, stents. But along came antiplatelet agents, which really revolutionized anticoagulation regimens as well. This is a slide of ticlopidine in angioplasty, and comparison of antiplatelet therapy with this prolonged anticoagulation that they would do with stents. And they clearly showed that with ticlopidine, you could have a brief period of anticoagulation just peri-procedurally, and not really need that long anticoagulation for a month with the heparin to warfarin bridge. And so anticoagulation became a thing that we would do pre and peri-procedurally, and not so much as a long term regimen. So why do we anticoagulate still with PCI? So the key reasons are: one is to mitigate the sequelae of iatrogenic plaque rupture that happens with elective PCI. In ACS, there's already some plaque rupture which can get worsened with more ballooning and stenting. And the second thing is the risk of thrombus formation on PCI equipment, or wires and catheters and guides can also develop thrombus. This is just a quick slide of the physiology behind it, and what are the target areas for anticoagulation regimen. The central component of all these thrombotic events is thrombin, which is factor 2A, and iatrogenic damage to the endothelium during PCI, it leads to increased expression of tissue factor, which you can see right here in the little green. In ACS situation, this is a spontaneous event, and there's superimposed iatrogenic injury. This tissue factor is an integral membrane protein. It serves as a receptor for factor 7. And once bound, factor 7 undergoes an autoactivation, forming this extrinsic 10-ACE component. And they lead to, that's an activator of factor 9 and 10. And 9 goes down your intrinsic 10-ACE pathway, and 10 goes down your prothrombinase pathway. And this intrinsic 10-ACE pathway, it activates factor 10 at 50 to 100-fold faster than this extrinsic 10-ACE does. And that plays a critical role in the amplification of factor 10A and thrombin generation and this accelerated thrombosis that happens. This thrombin that's generated in this entire process finally leads to conversion of fibrinogen to fibrin, which sort of goes along with platelets and forms the clot. In addition to the coagulation system, the vascular injury, activation of the coagulation system, vascular injury also simultaneously activates, it triggers platelet adhesion and activation. And thus, targeting this thrombin also inhibits further clotting by means of reducing the platelet activation and aggregation as well. And these two are the components of vessel injury mediated clotting. There's also a pathway for catheter thrombosis, which we cannot ignore, and because coronary catheters and other blood contacting devices like stents, mechanical heart valves, they probably trigger clotting through this mechanism via factor 12. So since the start of angiography, anticoagulation has been used to mitigate these thrombotic effects, in both an ACS and iatrogenic vessel injury. But anticoagulation obviously is a two-edged sword, like we spoke, and several studies have showed that bleeding events are similarly associated with short and long-term mortality after PCI, just like ischemic events. And this slide shows that the people with bleeding, that's in the black bars, you can see do as worse as people who have a thrombotic event related to or after the PCI. So it's an equally bad prognostic event. So what are the available anticoagulants that we have at our disposal? So we've got unfractionated heparin, we got low molecular weight heparin, we have a synthetic pentasaccharide called fondaparinol, or Arixtra as a brand name, and then we have bivalirudin, which is a direct antithrombin inhibitor. Heparin is by far the main anticoagulant that we use in angioplasty. This is just a quick slide about how heparin works. So heparin acts as an anticoagulant by activating antithrombin. This was previously called antithrombin 3, and it accelerates the rate at which it inhibits clotting enzymes, particularly your thrombin, right here, and factor 10A, right here. To activate antithrombin, heparin binds to this unique pentasaccharide sequence via this unique pentasaccharide sequence found in a third of the chains of commercially available heparin. Heparins which do not have this pentasaccharide sequence marked here in the red, they have little or no anticoagulant activity. So once bound to antithrombin, heparin induces a conformational change, which makes it inhibit factor 10A by 2 orders of magnitude. But it has little effect on thrombin. The way it inhibits thrombin is by bringing it, it serves as a template that binds antithrombin and thrombin simultaneously, and it just brings it closer to promote its degradation. So it's two mechanisms by which heparin is working, both by factor 10A inhibition and thrombin inhibition. A quick historical perspective on heparin. The credit of discovering heparin for a long time was given to W.H. Howell, who was a faculty at Johns Hopkins. His interests were in substances controlling blood clotting. He thought there was a balance between clotting inhibitor, which he called as antithrombin, and a procoagulant, which he called as thromboplastin. He was working with a substance extracted from dog brains called cephalin, and he enlisted this med student named Jay McLean to find out if this was a contaminant or does heparin really have anticoagulant properties. So McLean, really took on this project, and he found a similar and more reliable substance in dog liver, and hence the name is heparin, and hepar is liver in Greek. And he showed it to Howell that it's actually a substance, and he was able to isolate it from the dog liver. He later left to UPenn, but the work was continued by Howell, and he enlisted another med student named Holt. And so this cardinal paper, which demonstrated heparin's activity, carries Howell's and Holt's name. Later, really bringing it to mainstream can be credited to Charles Best, who's also famous for his work on insulin. He assembled a huge team of biochemists, physiologists to develop a cheaper and reliable way of heparin of preparation. In the first series of papers, they used bovine liver to increase the heparin yield, and the rest is history. And heparin became a mainstay agent used in anticoagulation for various reasons, for thrombotic conditions, cardiopulmonary bypass, etc. McLean went on to other things, but the popularity of heparin, he felt that he has not been given due credit until the 40s. W.H. Howell was credited with its discovery, but McLean had a great relationship with Howell, and he respected him as a superior and a teacher and a mentor. So he sort of kept his campaign a little discreet until Howell's death in 45. And after he died, he wrote a long editorial, writing about how he helped discover heparin. And finally, he was given some credit. And in the 60s, in Johns Hopkins, they commemorated his efforts and gave him a plaque, or put up a plaque in Johns Hopkins. So that's kind of the history of heparin. And the manufacturing of heparin has gone a lot of evolution after that time, and now it's pretty standardized. But it's sort of a very crude process, it's mainly the mucosa it's right now the source is mainly porcine. So the mucosa is scraped from intestines, from pork intestines, and then the slop is sort of stabilized using a preservative, and then digested with some enzymes, or proteolytic enzymes, or some chemical means. And then this heparin is precipitated by a low pH, and then dried, and a suspension is made. The first heparin production used canine or bovine livers as a source, but mainly, and now it's porcine intestinal mucosa that is used, and that's the only FDA approved source of heparin at this time. And the bovine source of heparin really decreased significantly after the mad cow outbreak in the 90s. But there's some concerns that have been expressed that there's a risk of shortage of heparin because of just single source manufacturing, and also most of the manufacturing is in China, which also poses a little bit of a concern. And heparin comes in 1,000 units per ml, 5,000 or 10,000 units per ml concentrations, which our nurses mix up and deliver during angioplasty. So this is a little slide on pharmacokinetics of heparin. Binding of heparin to endothelial cells is mainly how it's cleared, and that's the dose-dependent clearance. At low doses, the half-life of heparin is short because it rapidly binds to this endothelium and macrophages. This is a saturable phase of heparin clearance. After that, there's this non-saturable renal clearance part of heparin, and that's why the half-life of heparin is longer with higher doses than it is with shorter doses. And in the circulation, a number of proteins compete with antithrombin for heparin binding. And so that's why there's some unpredictability to its anticoagulant activity. For example, acute phase reactants, which are elevated in ill patients, in ACS patients, there can be a varying response to heparin. So that's why we monitor our coagulation very carefully using ACTs to ensure that there's a therapeutic response. Heparin, how do we monitor heparin? So in in conditions in which we're just giving a heparin drip, we usually use APTT levels. You can also use anti-10A levels, but neither of these are available in real time. And hence there's a need for something to measure heparin's action in real time. And that's why we check ACTs, which were initially developed in the 60s for use with cardiopulmonary bypass. So essentially, blood is placed in contact with an activator, and that could be a various different activators, cellite, glass, or kaolin, which is now used in most methods, which is pretty recent. And until now, it was mainly cellite, and is just reported as a number of seconds until a clot is formed. There are various vendors of ACT measuring devices that are there. There's a Medtronic device, there's a Hemocron device, and ACT Plus, which is also a Medtronic device. What we use here is iStat, which is another device to measure ACT. And there's some reported variability in the results that you get from various devices. This is a study. This is an in vitro study in which they used fresh blood, 600 mLs of blood, and they put some heparin in it, and achieved an approximate concentration of 1.7 units of heparin per ml. And then they connected it to a roller pump, and they simulated circulation. So the blood is circulating at 200 mLs a minute. And then they collected multiple samples using various ACT devices. And it shows that there is variability in ACT values. The variation seems to be more with the Hemocron device than it is with other devices. And relevant to us, the iStat device tends to deliver a little lower ACT value than your ACT Plus device or Hemocron device. But there's a caveat with this study that iStat has also gone evolution, and this was probably done with the cellite cartridges and not with the kaolin cartridges that we use now, which they say is a little bit more closer to ACT Plus in terms of ACT values. This is an in vivo study of iStat and Hemocron. It also shows that around the 200 range or 240 range that we usually are around for our procedures, they're pretty comparable. And in the higher ranges, iStat may be giving you slightly lower values. So how soon do we check an ACT after we give heparin bolus? This is data from cardiac surgery, and in that there's a real need for them to administer the heparin as close as possible to the start of cardiopulmonary bypass, so that they avoid excessive bleeding due to the prolonged coagulation time in the early stages of the operation. So they're really interested in these minutes immediately after heparin delivery. Although they do give higher doses of heparin, this study really shows that you can start checking your ACT at 2 to 3 minutes after delivery of heparin, and there's not much difference with 5 minutes. So, this was something that I didn't know as well, because I would be routinely checking ACT values sort of the 8-9 minute range after delivering the heparin, but looks like 5 minutes is more than sufficient to check an ACT. So we do routinely check ACTs during angioplasty. We're really dedicated to that. But does ACT affect outcomes? These slides are from the era of Ppca, in which stent was mainly a bailout strategy for dissection, etc. And this is from the Duke database, and it shows that abrupt closure is much higher in lower ACT range, and it's sort of a continuous decline in abrupt closure as your ACTs during your procedure increases. On the right-hand panel, there's another study in which here they say complications, which is essentially emergent CABG or death. They showed that were lower with higher ACT values. ACT-guided heparinization is not well studied. I had imagined that there would be a lot of studies about various ACT values and stuff, but this is mainly observational data to find out what is a good ACT range to work with. The only trial quality data is from Future Oasis 8, which is non-ST segment elevation patient MI patients who were treated initially with Rixtra. And after that, they underwent PCI, and they were randomized to a low dose heparin, and which was 50 units per kilogram, or a standard dose of heparin, 85 units per kilogram, or if GP2B3 inhibitors were given 60 units per kilogram. and then with ACT guidance. So in this, what they used was in the protocol, they would target an ACT of 250 to 300 according to the Hemotech device if they were just giving heparin. And if they were giving GP2B3 inhibitors, they just actually 250 to 300 with GP2B3 inhibitors and 300 to 350 with just heparin. And they sort of showed that a lower dose of heparin may not be ideal, and this targeted therapy may lead to improved outcomes, as you can see in the right panel, with no difference in bleeding. So that's where the recommendations and the guidelines as well come from about the ACT targets. This is though from ACS population and not from a stable ischemic heart disease population. So we cannot interpret this for that population. So as I said, there's no randomized trial data about what level of ACT is good. And there are a lot of observational studies. I marked the bleeding with red and the thrombotic events with yellow. Essentially, it seems like under 200, definitely ischemic events may be higher. And more than 325, there seems to be a bleed signal. So somewhere in between, we are probably okay. And as I said, no study has prospectively assessed the value of ACT guided heparin administration as compared to standard dose heparin without GP2B3 inhibitors. The study we showed was using GP2B3 inhibitors. We'll sort of just glean over this, that there is some effect with transradial and transfemoral PCI. There's more bleeding that occurs at an ACT of greater than 290 for transfemoral PCI, but this effect is not seen in radial. So hence, as we would expect with femoral, maybe staying a bit more careful with the heparin may make sense. So that's heparin and how we administer and monitor heparin. There's also other anticoagulants, which we'll quickly go over, which is low molecular weight heparin and fondaparinol. Low molecular weight heparin is smaller fragments of heparin, and heparin is broken down by enzymes or chemical depolarization to get your low molecular weight heparin. It has a lower molecular weight, obviously, hence the name, which is about 5,000, and that's about a third of heparin. And after a bolus of 0.5 milligram per kilogram IV, a therapeutic level is achieved within minutes and maintained for 2 hours. And that's a source for the recommendation of how to administer low molecular weight heparin during PCI. Fondaparinol has an even smaller molecular weight, and it's synthetic, and it's only this pentasaccharide sequence and nothing in addition. So that only binds to 10A, and it is not long enough to bridge the thrombin. So hence, mainly low molecular weight heparin and fondaparinol are essentially 10A inhibitors. Low molecular weight heparin has some thrombin effect as well. And then we have, approved parenteral direct thrombin inhibitors, which are lipirudin, argatroban, and bival. Lipirudin and argatroban are mainly treatment of HIT, but bival is approved for PCI as well, including for patients in HIT, because it has the shortest half-life, and hence it was used in the trials for PCI. There's some advantages to bival, and that's why it's become so popular, and there's been so many trials trying to prove its efficacy. And its main advantages are there's no activation of platelets, and heparin and heparin-like products have some effect on platelet activation. And bival also acts on clot-bound thrombin, which heparin does not have an effect on. Plus, it has a short half-life of just 25 minutes and more predictable response, and we don't have that variation in response as we get with unfractionated heparin, which can be a source from either variation in how your chains are within the heparin or patient-specific factors like inflammatory states, etc. Those disadvantages are not there with bival. The main disadvantage, though, of bival is that it's 400 times the cost. So this is from the guidelines, European guidelines about dosing for anticoagulation and what we use in PCI. Heparin we know about, and there are these two separate recommendations for whether you use a GPI inhibitor or not, and that is, as we saw, sourced from the Futura trial. For enoxaparin, because it has greater 10A activity, it cannot be readily monitored with the point-of-care ACT, and so hence you need direct measurement of anti-10A levels. It's not feasible during PCI, and so there's no way to monitor low molecular weight heparin effect during PCI, but we can administer these pre-specified doses because they've been studied in trials, and they show that they're strongly linked to anti-10A levels, therapeutic levels, which is greater than 0.5 units per ml. And so these doses are essentially standard doses that we administer and conduct our PCI. So we look at anticoagulants in different situations. So there's anticoagulation for a stable ischemic heart disease, and that's different from your ACS population because of the prothrombotic nature is greater in ACS population. So let's first look at anticoagulation in stable ischemic heart disease, and what is the evidence for it? How intense does it need to be? This is a provocative study, which is a Chow study. It was a non-inferiority trial of 700 patients in which all of these patients were preloaded with Plavix. And again, this is the stable ischemic heart disease population. All these patients are preloaded with Plavix. And in this study, they only carefully selected only those lesions which were in a native coronary artery segment, not bypass lesions, etc. There were these vessels were greater than 2.5 millimeters. There was a greater than 70% stenosis. It was focal and not greater than 30 millimeters, and was not calcified. There were no important side branches. So you're really super type A lesions. And in this trial, what they did was, in fact, randomize patients to either heparin or no heparin. And this trial was something that I was not aware about, and I think is really provocative. And they showed that there was no difference, or at least there was a non-inferiority of not giving any heparin for a patient with stable ischemic heart disease versus giving heparin. Sort of blows us away. There was some criticism of this trial that the non-inferiority, the upper margin for non-inferiority in this trial was more than double the event rate. So one could potentially have like a 2.5% complication in the heparin group, and 5.5% in or 5.4% in the tested group, which is no heparin, and still meet in non-inferiority criteria. So, we're not entirely sure if it's equivalent to not giving any heparin, but it's really provocative. And the main take home from this trial is that if you preload a patient with antiplatelet agents, and especially with the newer antiplatelet agents, one could conceivably have lower ACT values for stable ischemic heart disease and probably be okay. So this trial gives a lot of food for thought about anticoagulation in type A lesions and stable ischemic heart disease. So the Chow trial, we saw, that's controversial and thought-provoking, but what heparin dose do we use for stable ischemic heart disease? There's only one trial in this, which is the ISAR-3 trial, which is a heparin versus bival trial, but they used a dose of 140 units per kilogram dose. So in this trial, which is ISAR React 3A, what they did was, this was a non-randomized trial. It was done subsequently, and they just recruited patients and gave them a dose of 100 units per kilogram and compared it with this historical control from ISAR React 3 of 140 units per kilogram and showed that there was less bleeding complications. So a dose of 100 units per kilogram has been tested in stable ischemic heart disease, and that seems to be a reasonable dose. And so hence the recommendation is the same as for other conditions. We usually give 70 to 100 units per kilogram bolus. What's the evidence for low molecular weight heparin in PCI for stable ischemic heart disease? Can we use it? This is the STEEPLE trial. It was mainly a femoral approach, and elective PCI. And patients either received enoxaparin at 0.5 or 0.75 milligram per kilogram body weight IV, or unfractionated heparin adjusted for clotting times of 300 to 350. And when procedures were prolonged by more than 2 hours, in the enoxaparin group, they gave a half the original dose bolus. In this trial, there was a 40% GP2B3A use, and 95% of patients got thienopyridines as well, but there was no preloading. And enoxaparin at that dose of 0.5 milligram per kilogram IV was associated with actually a reduction in non-cabbage related bleeding, and compared to heparin. So it essentially shows that enoxaparin can be safely used in PCI with no increase in bleeding, but this trial was not powered to assess whether ischemic events are increased or decreased with low NOx. Coming to bivalve in stable ischemic heart disease, what is the evidence for bivalve in stable ischemic heart disease? And essentially the data is from the REPLACE-2 trial, which is in 2003, but this trial was all comers, but 50 to 60% of these patients were stable ischemic heart disease. They were randomized to bivalve with the provisional GP2B3A inhibitors, or heparin with a 65 unit per kilogram bolus, and GP2B3A inhibition was standard. 96% of them in the heparin arm received this GP2B3 inhibitors, and all of them received aspirin and thienopyridines for at least 30 days. 85% of them were preloaded as well, and it was mainly Plavix in this trial. So in this trial, they showed that bivalve with provisional GP2B3A is not inferior to heparin plus planned GP2B3A during contemporary PCI with regard to suppression of ischemic endpoints, as you can see here, and it's associated with lower bleeding. This is the ISA REACT-3 trial. The goal here was to see whether heparin without GP2B3 inhibitors, how does it fare against bivalve in the stable ischemic heart disease population. So 4,500 patients in this, but they used a very high dose of heparin in this, which was 140 international units per kilogram, followed by a placebo infusion. And these patients, again, were stable and unstable angina, but without elevated troponins. At 30 days, there was no difference in ischemic outcomes, but they showed less bleeding with bivalve. But again, this was the 140 units per kilogram dose and not the 70 to 100 that we typically use. So whether the 100 units per kilogram dose beats bivalve in stable ischemic heart disease is unknown. Next, we look at anticoagulation strategies in non-ST segment elevation ACS population. So what heparin dose do we use? And this is, again, a slide that we just saw, which is from the future OASIS trial, in which they randomized patients to the low dose, which was 50 units per kilogram, versus your standard dose of 85, whether you do not use GP2B3A, versus 60 when you use GP2B3A, and they used ACD guidance in this study. And as you can see, the higher dose of heparin, which is your standard dosing, I should say, was superior to this low dose. And hence in the guidelines, this is the dose that we use for heparin, even in non-seg NSTEMI population. What about low molecular weight heparin in non-ST segment elevation ACS? This is a synergy trial in which this was tested. 10,000 patients, non-ST segment elevation ACS. And these patients were treated with an early invasive strategy. 55% of these patients received GP2B3 inhibitors, and Plavix was the main antiplatelet agent used. And because this is NSTEMI population, not all of them got PCI. 50% or so got PCI, 20% or so got cabbage. And they compared a heparin drip before the procedure of 50 to 70 PTT versus a low molecular weight heparin subcutaneous dosing of 1 milligram per kilogram BID. And if a patient is going for PCI, 8 hours after the last dose, then they gave this IV bolus of 0.3 milligram per kilogram IV. And they were able to show that there was no ischemic difference, but there was a tad more bleeding with low molecular weight heparin. And this is the trial from which we get this basis of the supplemental dosing for low molecular weight heparin when the patient has been on subcute, and if PCI is conducted 8 hours after the last dose, then we would give this extra dose of 0.3 milligram per kilogram IV. In this trial, there was also an incidence of increased bleeding that they noticed in post-hoc analysis in those who were treated with upstream enoxaparin or low molecular weight heparin, and then later who were switched to heparin. So thus, this trial is from where we learned that stacking is probably not a good approach. So if somebody has received enoxaparin and is within that 12-hour window, you would rather continue enoxaparin, either give a bolus IV, or if the dose was given recently, you can just continue with the PCI and low molecular weight heparin and not throw on unfractionated heparin on top, which is called stacking. Rixtra has also been tested in non-ST segment elevation MI, and it was compared to Lovenox. It showed similar ischemic events, a little lower bleeding and composite outcome, but there was a signal of increased catheter thrombosis in the population who got PCI, which is about 30 to 40% population in this got PCI, and in that subgroup there was an increased incidence of catheter thrombosis. And thus, when patients are on fondaparinol, we have to administer another antithrombin agent, such as heparin. And we do not do PCI in with patients who are on fondaparinol without anything else. Coming to bival, what is the evidence for bival in non-ST segment elevation ACS? So there are two key trials for non-ST segment elevation ACS and bival. One is the Acuity trial, which is a large trial of 13,000 non-ST segment elevation MI patients, and the Horizons AMI trial. The Acuity trial, which you see on the left side, non-ST segment elevation AMI population patients, 13,000 of them were randomized to either heparin or Lovenox along with GP2B3 inhibitors. A second arm was bival with GP2B3 inhibitors, and the third arm was bival. This slide just shows a comparison between the heparin plus GP2B3 inhibitors and the bival alone group. 60% of these patients got PCI, and 65% of them received Plavix. So this slide shows you that in patients with GP2B3 inhibitors, bival was associated with rates of ischemia and bleeding that was similar to that of heparin, but bival alone, which is actually what is shown in the figure, was associated with similar rates of ischemia, but significantly lower rates of bleeding, which sort of accelerated the people favoring bival in the non-ST segment elevation MI population. And the second side of the panel is ISAD React 4. And Horizons AMI was a trial that was done in the ST segment elevation AMI population, and that was positive. And the criticism of Acuity was that there's only 40%, there were 40% patients who did not receive PCI, and 40% of them had no biomarkers done. So ISAD React 4 was conducted with NSTEMI patients going for PCI, and heparin plus GP2B3 inhibitors was tested against bival. In this, the heparin dose that they used was 70 units per kilogram. Nearly all these cases were done femoral, although radial was permitted. And the results were similar, with similar ischemia with bival, but less bleeding. Bival, though, has not been studied in non-ST segment elevation MI against heparin without GP2B3 inhibitors. So all the data that we have for non-ST segment elevation MI is against heparin with GP2B3 inhibitors. Now going on to STEMI, which is where a lot of the trials have been conducted and focused. There are no trials evaluating the dose of heparin in STEMI population, and guidelines just sort of extrapolate what we know from non-ST segment elevation MI population, and we just use 70 to 100 units per kilogram when we do not use GP2B3A, and 50 to 70 units per kilogram when we use GP2B3A. Can low molecular weight heparin be used in STEMI or not? So this is a small trial, which is the ATOL trial. And these are STEMI patients going for PCI. And they received either IV Lovenox at the 0.5 milligram per kilogram dose or heparin at your standard 70 to 100 units per kilogram dose. And if GP2B3A was used, the lower dose of 50 to 70 for the heparin. If the procedure was prolonged, again, they would give that small 0.25 milligram per kilogram bolus of Lovenox in the Lovenox arm. A large proportion was done radially in this, 70%, and nearly everyone received Plavix. So at 30 days, there was no difference actually in the endpoints in this trial, and enoxaparin was marginally better. Again, we don't prefer low molecular weight heparin due to perceived inconvenience, but this supports evidence that IV enoxaparin can be used and is equally safe to heparin even with STEMI. Bivalirudin in STEMI has been a focus of a lot of trials and a lot of controversy as well. There are 3 or 4 large key trials of bival and STEMI. We'll go over those. The first trial is Horizons AMI, which is sort of the main trial which brought bival into the forefront for the STEMI population. So this is 3,600 patients undergoing primary PCI for STEMI. They're randomized to either heparin with standard GP2B3 inhibitors. So all of these patients got GP2B3 inhibitors. They used heparin at 60 units per kilogram dose versus your standard bival bolus and infusion per protocol. Everybody got Plavix. The access was nearly all femoral, 95%. And this shows at 30 days, in the primary endpoint at 30 days, that bival was superior. It had lower bleeding. It had lower net adverse clinical events. No difference in thrombotic events. And there was a reduction in mortality. There was a follow-up study up to 3 years, which showed that this mortality difference persisted even at 3 years with bival. There was a signal of an increase in stent thrombosis noted in the bival arm within 24 hours, but this difference was not significant at 30 days. This survival benefit that was seen with bival really gave momentum to bival use in STEMI, and a lot of proponents of bival started advising bival for STEMI. There's some question whether, is this related to whether antiplatelets are, what is the dose that's given, whether people were given heparin before the procedure or not. And this table shows that there was no interaction between whether patients got heparin before the procedure or not, what dose of loading was used, and things like that. The 1-year outcomes was stratified by access site, and they suggested that there was no difference by access site. But as you can see, the radial arm or the population that got radial was very low, barely 5%. So nothing really can be said about radial and how bival would do in STEMI from this trial, at least. So this is the first key trial for bival in STEMI. The next trial is the Euromax trial. This was again a randomized open-labeled study. This was designed to test whether bival initiated during transport for primary PCI in patients with STEMI was superior to heparin. And in this trial, they gave liberty for an optional use of heparin, as opposed to in the Horizons AMI, in which it was everybody needed to get GP2B3 inhibitors. Sorry, in Horizons AMI, everybody had to get GP2B3 inhibitors. In this trial, there was an optional use of GP2B3 inhibitors for the heparin arm. This again compared bivalve versus your standard heparin dosing protocol of 60 units per kilogram. And if only heparin was given 100 units per kilogram. Although in this trial, GP2B3 inhibitors were optional for the heparin arm, a lot of patients ended up still getting it, and 70% in the heparin arm still ended up getting GP2B3 inhibitors because that was sort of practice at that time. The radial access rates, though, in this trial were much higher than Horizon's AMI, and 50% got radial access. Antiplatelet agents as well, there was an increase in newer agents with 60% of patients getting prasugrel or ticagrelor. And again, they checked the primary outcome at 30 days. This again shows that bivalve delivered a superior primary outcome, which was a composite outcome again of bleeding and thrombotic events and death. And this primary outcome was mainly driven, though, by a reduction in bleeding. There was not much difference if you look at just the thrombotic events. So again, there was more evidence that bivalve may lead to less bleeding and similar ischemic events in the STEMI population. But with Euromax trial, again, the criticism remained that heparin was used with GP2B3 inhibitors in the majority of cases, 70% of them. And that was just the practice pattern. So there still remain questions about whether bivalve was still superior to heparin with more radial use, with newer antiplatelet agents, and without the use of GP2B3 inhibitors. And the third reason was one of the key questions that remained about the use of bivalve in STEMI. Then came along one of the most controversial trials in cardiology, which is the HEAT PPCI trial. This was done in the UK. It was a single center study, about 1,800 patients. It was open label, and they compared heparin versus bivalve. And in this trial, GP2B3 inhibitors were only used as bailout, and they ended up being used only in about 10% of patients in this trial. 90% of them received prasugrel and ticagrelor, and 80% of them were radial. And the bivalve was given at a standard dose. The heparin was given at a 70 units per kilogram dose, and they would bolus if the ACT was lower than 200. So this trial showed that heparin can reduce the incidence of major ischemic events in the setting of primary PCI without an increase in bleeding when compared to bivalve. And this trial really, came under a lot of scrutiny, and these investigators came under a lot of fire at ACC when they presented their findings. A lot of things were said, which are, some of them were borderline accusatory. I believe Greg Stone said that bivalve was underdosed. And then, it sort of degenerated into this conversation whether there was some intentional underdosing of bivalve, which was a big allegation. I think Roxana Meran also raised some questions saying that the trial was able to enroll 2,000 patients in under 2 years, and she was really concerned how that was done and things like that. So a lot of this was unfair sort of to the investigators because this trial really has a lot of uniqueness, which really helps us in practice, because this was a pragmatic trial. This was not, just like an explanatory trial in which they're trying to demonstrate the efficacy of one intervention versus other in an ideal condition. And this was more, they just tried to study heparin versus bivalve in the day-to-day clinical scenarios. So it comes to really being close to one of the best pragmatic trials that we have done in cardiology. There was another issue with this trial, which was with delayed consent. And this was also a contentious point in this trial because in this trial, they took consent from patients after everything was done. And the reason they said was that we're comparing two drugs that are in routine use during PCI. And the patient is experiencing a heart attack, they're in pain, they're under the influence of drugs. And approaching these patients in this setting, they felt that consent was not right to be done in that setting, which is really controversial. And and some ethical questions were also raised. So this really threw into question the benefit of bival in STEMI in today's era of more potent antiplatelet agents, more radial access, and no GP2B3A use. And this evidence was really uh, taken up quite well, and a lot of centers started reducing their use of bival because of its associated costs. There are a couple of other trials. One of them is the BRIGHT trial. And the reason this trial was done was because they felt the increased stent thrombosis with bival within the first 24 hours could be mitigated by a low dose, an extended infusion after the PCI is completed for 30 minutes to 4 hours. So in this trial, what they did was they wanted to determine if bival is superior to heparin um, alone and to heparin plus tirofiban during primary PCI. For the heparin alone arm, they used 100 units per kilogram. For the heparin with bival, they used a 60 with the GP2B3. Heparin with GP2B3, they used 60 with GP2B3A. And for the bival arm, they used standard bival infusion, but then they extended this infusion to 30 minutes to 4 hours after the procedure. This was done in China. 2,200 patients, 78% radial. Nearly everybody, I think, got Plavix, which is a big difference compared to heat PPCI, in which they had more potent antiplatelet agents. This trial showed that there was a decrease, in fact, in net adverse clinical events compared with both heparin alone and heparin plus GP2B3A. And this was, again, due to a reduction in bleeding events without a significant difference in cardiac or cerebral events. And they were able to reduce the risk of stent thrombosis with this extended infusion. This just shows the ischemic events were similar and the bleeding events were lower. The final trial for bival is actually a AMI trial. It's not STEMI, neither is it NSTEMI. 50% of these patients were STEMI. This is the Validate Sweetheart study, in which they recruited 6,000 patients, mixed bag STEMI and NSTEMI, going to PCI. They gave the bival at the standard protocol, plus they encouraged this continued infusion in the bival arm. The heparin was given at the 70 to 100 dose, and no GP2B3A was planned. It was only for rescue. In this, nearly all the patients got prasugrel and ticagrelor, and 90% of these patients were radial. At 180 days of follow-up, there was no difference that they saw across the board in both bleeding as well as thrombotic events. And when stratified by a STEMI and NSTEMI, there was, again, no difference. So this really is probably the most recent trial with more potent antiplatelet agents, suggesting that there may really be not much difference when you use heparin without GP2B3 inhibitors and compare it to a bival with your extended infusion. So these are the recommendations for the various anticoagulant agents in your stable ischemic heart disease population, NSTEMI and STEMI. And as you can see in STEMI, the European guidelines suggest unfractionated heparin to be preferred as opposed to bival. But the ACC guidelines continue to recommend both with a similar strength of recommendation. There are some special considerations for patients who are on oral anticoagulation, and we see these patients more and more often, patients who are on warfarin or the newer anticoagulant agents, and they do present for PCI as well. So what do we do for these patients? There's, again, no randomized data in this, and most of this, and there's no, in fact, even prospective studies. All these recommendations are based on retrospective analyses an expert opinion. PCI in patients with oral anticoagulation, it should be performed via the radial approach to minimize the bleeding risk. In elective PCI and PCI for non-ST segment elevation MI, if there is no thrombus burden, no additional anticoagulation is needed if the patient is on warfarin and the INR is greater than 2.5. There's another little study which suggested even 2 is fine. So if somebody is on warfarin and has a therapeutic INR, there are some retrospective data suggesting that it is safe to just do PCI without any additional anticoagulation. Although in primary PCI and in PCI in non-ST segment elevation AMI population, which has high thrombus burden, expert opinion suggests to use additional anticoagulation, regardless of the timing of the last dose of oral anticoagulant. When patients are on dabigatran, it may be preferred to use bivalve over unfractionated heparin or enoxaparin because it's a direct thrombin inhibitor. On the other hand, if somebody is on anti-10A agents like apixaban, edoxaban, or rivaroxaban, this prior exposure to these agents, enoxaparin actually may be a preferred anticoagulation strategy, and this would avoid the switching from the anti-10A agent to heparin. So that's something to keep in mind. Okay. All right. So that is sort of looking at all the evidence that we have for the 3 populations of PCI that we do, and the role and evidence for each of these anticoagulants. So we're sort of at the end of the hour as well. Is there any questions or comments?
So Karthik, yeah, this is Steve. I just have one quick question for you about bivalve. Just a summary. What's your impression of the data? Do you think there is or is not evidence for increased early stent thrombosis when using bivalve?
Well, the trials which did not use the extended infusion, there was clearly a risk of increased stent thrombosis at 24 hours. This effect did not persist till 30 days, but it's definitely there. So if we are using bivalve, I think using the extended infusion should be recommended to reduce that risk. But having said that, despite using the extended infusion, the last study which came out, which was the most recent one, which was the Validate Sweetheart study, there's really no advantage of bivalve against heparin when we use the newer, more potent antiplatelet agents and low use of GP2B3 inhibitors and radial access. So when somebody is using femoral access, I guess like operators would sometimes still prefer bivalve. That is not a practice at Yale, at least that I've observed, but that is done at a lot of centers when patients have femoral access for STEMI. Sometimes they will prefer bivalve.
Okay, thank you. I think the hour's long and your audience is fading, so I think we'll probably just end it here if that's okay.
All right, sounds good.
Thank you very much, Karthik. I appreciate your persistence under tough circumstances.
Yep. I'll see you shortly.
Great, thank you.
Bye.